Thanks for joining us today. My name is Sheena George. I am with AMA ACT team, the Accelerating Change Transformation team, and I'm here with my colleague Anila.
Hi, good morning. This is Anila from the HQCA, the Health Quality Council of Alberta, and I'm a lead with Health System Improvement team, and I predominantly work on the panel reports at the organization.
So Anila and I are going to present an information session today on how the CII CPAR and panel reports improve continuity. Our objective is to specifically look at the CII CPAR and panel reports with the assumption that you are familiar with CII CPAR primary care tools and resources, and you've reviewed the CII CPAR videos as well as the HQCA's webpage, understanding the data and where it demonstrates how QI teams can engage physicians to review their panel reports. We've included the links here for reference. So why should we focus on continuity? What you see on the slide is Alberta data, and it reflects the degree of continuity, and that's shown by less than 50%, between 50 and 75%, and over 70%, that continuity has an impact on hospitalizations, length of stay, which is LOS, and cost to the system. Those patients shown in pink with the highest continuity, so these are the patients that see their family doctor over 75% of the time, these patients are 6 times less likely to be hospitalized than patients with less than 50% continuity to their primary provider. The key message on this slide is the importance of socializing that continuity makes a difference, and high continuity has an impact on clinical outcomes. Further evidence shows that mortality is affected by continuity. Again, Alberta data, where the higher the continuity between a patient and provider, the lower the mortality rate. So where does CII CPAR fit with the patient's medical home? The College for Canadian Family Physicians had a vision document, and in that vision document, they talk about the foundations and functions and commitments that describe what a patient's medical home is. In Alberta, we had the implementation model. Now, the implementation model focuses on how do we actualize a patient's medical home. And when you look at this model, you can see that panel and continuity are key steps in building the patient's medical home. Continuity is multidimensional. It's about improving the health of Albertans through stronger ongoing relationships with their family physician and team, along with the ability to identify in the system who the primary provider is, the quarterback of that patient's care. When we look at CII CPAR, it's important to understand that CII, Community Information Integration, it's a system that transfers select patient information between community EMRs. It's coming from the community clinics. By sharing that information, other members of the patient's care team has access to it through Alberta NetCare. CPAR, the Central Patient Attachment Registry, that's that provincial system, and it captures the confirmed relationship of a primary provider and their panel patients. Together, CII CPAR enables health system integration and improved continuity of care that are both essential and foundational elements in the patient's medical home. The Auditor General has reported that there is discontinuity in the system. There are individual parts that are still working in isolation to the others. By participating in CII CPAR, you're improving that continuity because there is now an opportunity to identify the right person and team that needs the right information at the right time to achieve better patient outcomes. So how does it actually improve that continuity? At a high level, it's important to understand how CII CPAR shares information from primary care and how these community clinics and physicians and teams receive information to now enhance NetCare, the provincial health record. So what information is actually shared? Confirmed panels are now uploaded automatically from community clinics to go into CPAR, that provincial database. Select mapped encounter information that could only be accessed within the community clinic is now also shared with the system. The consult reports, and this includes consults from community specialists as well as family physicians who specialize, multidisciplinary team members that write consults. What the clinic receives as a result of participating, family physicians that have uploaded their panel will now receive e-notifications. E-notifications will inform the primary provider when one of their CPAR panel patients has had an emergency department visit, a hospital admission, discharge, or day surgery, and it comes directly to the EMR, somewhat like a lab report. Now, the conflict reports are another type of report that they are receiving. This is where the primary provider has an opportunity to see if their panel patients are on another provider's panel. It's the first time community physicians can see where there is duplication and can now work towards a unique panel list. The next report is a demographic mismatch report. This report allows teams to see if one of their patients has become deceased, has information in their community EMR that needs to be updated. So now that the right information is available to all providers that connect with that patient throughout the system. So how does the sharing and receiving of this specific information enhance net care? Well, the Community Encounter Digest, it's a 12-month rolling snapshot. It's a snapshot of the care in the community for those enabled clinics. Because it sits in NetCare, that information is accessible to all providers in that patient's circle of care. The console reports are also accessible to anyone in the patient's circle of care and not just the referring family physician anymore. And in the future, NetCare will be the only place in the system where the primary provider's name will be displayed and can be accessed by hospital clerks and community team members. We also are expecting a complementary report to that Community Encounter Digest, where we get a patient summary report that provides more details and will have more benefits for those patients with complex care needs. So far, we have several physicians and clinics participating, and we're seeing benefits are being realized. The HQCA has conducted 2 formative evaluation reports, and in those reports, we have physician and team testimonials. What we're seeing is that e-notifications are informing family physicians when their panel patients have been discharged from hospital for smoother transitions of care. This will be a key enabler for the new initiative, Home to Hospital to Home, H2H2H. For the Community Encounter Digest, we're also hearing from care teams within the hospital systems as well as the community, where that snapshot of care is providing the right amount of information so that ER teams can see if the patient has presented with the problem before, if someone else within their care team is already addressing the issue, where they're telling us they feel like they're no longer flying blindly when they're able to access that CED. Console reports are showing the same impacts. CPAR is giving primary providers and team the feedback they need to start doing that active panel management, where they can now start to see how they're impacting relational continuity. So improving that continuity through conflict reports, let's dig into that a little bit more. This is where we know when your patients are confirmed to another provider. As a reminder, there's a lot of terminology out there when we look at the different EMRs. In the EMR specifically, the platforms could call confirmation, verification, or validation. All mean the same thing, except we're choosing here to use the term confirmation for the clinic processes. So when clinics are participating in CII CPAR, they are confirming that patient-provider relationship, and that confirmed panel is what is going up to CPAR, that provincial database that is validating the information within CPAR. What it validates is that it's showing when there are patients that are attached to other participating physicians. When the conflict report is available, it can be downloaded every month. Teams within clinics can then use their EMR to start their verification process. This is where they're using the conflict report to determine outreach opportunities to reach out to patients and do that active panel management. So what would that actually look like using a panel conflict report? So what you see on the screen here, the report comes in a CSV format and it can be sorted in Excel. There's value in sorting each of the columns. What results is the ability for this list to become an actionable list. So if you see, the first arrow shows you that category 1 column shows you the primary provider has a confirmation date that is more recent than the other conflicting provider, and that's within a period of 30 days or more, so 1 month or more. Now the conflict category is shown here. It's important to know you can sort by 30 days or more, or within the last month. You'll know when that conflict was first reported. You'll understand who the patient is, as their ID will be presented. You will be able to sort by last name and first name, by their date of birth, their gender, as well as understand the last confirmation date with the physician who has submitted the panel and any of the physicians that are conflicting that have also had the same patient who responded yes to the panel confirmation question, the date of the last visit to the primary provider, and the last visit to that conflicting provider. You'll know their names and the facilities that they are working in. So how does it become that actionable list? You can see the same report when it's sorted by category 2. So again, the confirmation date is the same or within 1 month between the different providers? Is there any duplication? Are patients going to more than one family physician participating in CII CPAR? And here you can see that Sean last saw his family physician, Dr. White, on November 19th. That was the date of his last visit column. But he was also last confirmed in the EMR on September 22nd, the last confirmation date column. And based on Dr. White's conflict report, Sean has also seen 4 other family physicians, all within the last 30 days. And he said yes to the panel confirmation question to all of these doctors. Now, if you're focusing not just on the duplicate patients, but you're wanting to look at your most vulnerable patients on your panel, you can sort by the date of birth. We know when we look at the continuity research how important it is to understand your elderly patient population. So you can prioritize that actionable list and start to sort by the date of birth. What we see here is that the most vulnerable panel population, where we know based on the CPGs, the clinical practice guidelines, we can see that this patient has also seen another conflicting provider. It's an opportunity to maybe reach out to these patients first. Another method of sorting the report is looking at the conflicting provider. Filtering by this column will show you if there are patients on your panel that may be going to clinics with different models of care. Could it be because they need more episodic care, sore throats, tummy aches, or does this walk-in clinic actually offer them also that longitudinal model where they're doing the screening and the chronic disease management that you also may be offering to the same patient? So again, sorting by the conflicting provider facility gives that next opportunity to start to see where you can improve the relational continuity. So looking across the province at our conflict report data from March to September of 2020, the blue bars represent the number of panel conflicts from the zone in CPAR. The orange line represents those conflicts as a rate. For most zones, as participation grows, so does the number of conflicts and the rate of conflicts. Now, if we look at Calgary zone, you can see there's fewer conflicts in this zone. They have over 1,000 family physician members and a zonal population close to 4 million. When you look at their line, the participating clinics are spread out, so you can see that reflected in the data. In Central Zone, they had one of their first PCNs and had almost all of their clinics live on this system. So you can see it has a slightly higher conflict rate and then it starts to go down lower. You can also see these clinics, as more clinics are participating, the geography and the distance between them. Edmonton zone is similar to what we see in Calgary. There's a big difference in what we're seeing in the North zone. To date, this zone has the highest number of physicians and clinics participating in CII CPAR, and some of that participation is from some very tight geographies, specifically 2 large clinics in a small town in 1 PCN, McLeod River. On the next slide, we'll focus some more on this data. In the South Zone, you'll see by looking at the data, they started with 1 PCN in the region participating in CII CPAR. They were working hard on their conflict resolution reports. When another PCN joined in the region, you can see that the conflict rates increased. So focusing in on McLeod River, this is where you can see that they started off when you had the first clinic, a 7.034%. When the other clinic joined, the quality improvement team doing multiple PDSAs, plan to study act cycles, testing their outreach and opportunistic scripts, reaching out to their patients, working with the clinic, they were able to bring their conflict rate down from 7% to almost 1.9%, almost 2%. It's amazing data to show how these reports can grow the potential for relational continuity and do become actionable lists for clinic teams to work on. So now that we've talked in detail about the CII CPAR reports and the live data to date, I'm going to hand it over to Anila, who's going to focus on the panel reports and how those have the opportunity to improve continuity.
Thank you, Sheena. So going into this webinar, we're assuming that most of the audience here understands what a primary healthcare panel report is. But just as background, so panel reports are provided to family physicians by the Health Quality Council of Alberta every year by request. And they're a personalized summary about the physician's patients or their panel. It includes things like panel size, the burden of illness of that panel, screening rates, continuity rates, and how the patient uses healthcare services, both with that physician and outside of the clinic walls. As a reminder, the reports are confidential and they're available annually, and they don't require additional data collection in order to be generated for a physician. So going back to this webinar and understanding a bit about how do these panel reports ultimately help improve continuity for patients. So a couple different ways. So it's one of the few reports where you can actually begin to identify who has low continuity. So using a PHN, you can actually drill down to see who might be a patient who does not have high continuity to that provider. Another way that you can use the panel reports is to understand baseline continuity and track how CII CPAR is actually improving continuity over time. You saw through Sheena's data some of the changes as physicians have been on CII CPAR for a while. So you could imagine ordering a panel report, understanding current continuity, and then a year later, understanding how that continuity has changed. And lastly, because you can begin to identify who falls in the low continuity category, you can actually start to improve care for those patients. So just as a reminder, there's two different types of reports at the high level. So one is called a proxy panel report. And this is where a physician would say, I'm not super confident in my panel management practices, perhaps, and I feel more comfortable if the HQCA generated a panel for me based on billing patterns and how a patient uses healthcare services. So HQCA uses a 5-cut method to then generate a panel for that physician. Another option is a physician says, I have pretty good panel management practices in place and I feel pretty confident about who my panel is. In that case, a physician would request a confirmed panel report from the HQCA, where they may say, look, these are my 1,200 patients. Can you please produce a panel report specifically on those 1,200 patients? Benefit of going through CPAR to request a confirmed panel report is that if a physician is participating in CPAR, they don't have to send us a panel to the HQCA. They could simply participate in CPAR, let us know they're a CPAR physician, and we can pull that panel list that has been sent to CPAR and produce a panel based on that. Some of the benefits of a confirmed versus a proxy report, as you can imagine, is one is definitely trust. So certainly in a proxy, we're estimating at the HQCA who the panel is, and the confirmed, the physician is saying, this is my panel. So it increases trust in the data. And certainly there's a lot less paperwork involved because all you have to do is request a panel report each year, and we produce that based on the CPAR panel. So I wanted to show you what this measure looks like in the panel report. So what you're looking at now is called patient continuity to a physician. So this is a measure that's available in the report. You can begin to identify for that physician how many patients fall into the high, medium, or low category for continuity. But what's really neat is assuming your physician is part of CPAR, they can actually drill down to identify, well, okay, so I understand that my blue bar here is small, and let's say only 11% of my patients are in the low continuity category, but who are those low continuity patients? So you can actually see using the table below how many fall into high, medium, or low. And for the low, you can click to understand who that 123 is. So Sheena, if you want to pause your screen, I can actually show the audience how to do that in their own report. So when you first sign in, this is what the report will look like for you or for the physician that you're working with. And if you want to understand that continuity measure that we were just looking at, you would click on panel characteristic. Perfect. So when a physician signs into his report, or when a delegate signs into his or her report, this is what the welcome screen would look like. And so the measure that we're talking about today is patient continuity to a physician, and that lives under the panel characteristics section. So you would click on panel characteristics, and then you would drill down into patient continuity to a physician. So this is a screen that we were just looking at. Just to orient you a little bit, on the very kind of right-hand side, you'll actually be able to understand in a couple sentences what this measure is about and why certain patients might be in a high or low continuity category, along with some resources like the relational continuity CPG from the ACT team. So let's talk about this 123, right? That's what we were interested in. So who are these people and how can I begin to action care for these individuals? So you would click on that number and this screen would pop up. And what's really neat about this is in a confirmed panel report, you'll actually see the PHNs of those 123 patients. If you look at Sheena's example, when she was showing you those conflict reports, So how do you begin to narrow that 123, right? So Sheena had a couple ideas in hers that we could probably leverage for the panel reports too. One idea was, well, why don't you sort by age? Why don't you look at those that perhaps are 65 and above? So for this panel, let's go to patients that are 65 and above. And it narrowed your list down from 123 patients to 5 patients. Well, that feels a lot more actionable. For me to get in touch with 5 patients is a lot easier than for me to get in touch with 123 patients. Another option is you might say, well, let me look at burden of illness. And I know that continuity is probably most improved for my major chronic patients. So you click on major chronic, and let's see what happens to this 123 list. It goes down to 2 people. Okay, again, a more manageable size. So these are different ways that you can kind of cut and slice the data to begin to understand who's falling into your low continuity category and improve care for those individuals. So we've just seen how this looks like in the live environment, but we've left this slide in the deck for you so you're able to identify it and use it as well. So just a summary, you can identify your low continuity patients by PHN. Um, you can begin to narrow your low continuity patients by age and burden of illness as an example. And all of these lists, that 123 list of patients or the list that we narrowed down, can all be exported to an Excel file for easier use, or they can be printed, whatever is easier for you, by using the top right-hand button that you see circled here. Okay, Sheena, now over to you.
Thanks, Anila. Okay, so now let's go back to those CII CPAR reports and look at the information that we are receiving as a community clinic and team. So we know we get e-notifications. And so what the CPAR e-notifications are is when you know your patients are in and out of hospital, in and out of day surgery, or discharged from the emergency department. So what's the data showing us? So here is where we see that growing potential for smoother transitions of care provincially. So again, it's looking at data from March to September of 2020. Now the graph shows that as more physicians participate in CPAR and submit panels to the registry, the population of Albertans in CPAR grows. So the number of patients in CPAR is dependent on the physician participation. So where the orange is the number of providers submitting, and the blue line is the number of patients on those panels in CPAR. So looking at the data, by September of 2020, nearly 200,000 Albertans had their primary provider participating in CPAR. These Albertans had their physicians and teams eligible to receive an e-notification if any of them were discharged from hospital or ED. So on average, over 2,000 e-notifications are sent each week to the primary providers participating. Again, opportunities for smoother transitions. So let's break it down further. What does that look like for the average physician participating? So in a day, we see about 1.7 notifications arriving. So in a week, if you had 1,000 patients on your panel, that's about 14 e-notifications in a week. The average is slightly higher for rural physicians than our urban physicians. Important to note that the e-notifications are essentially real-time data. The e-notifications arrive in the community clinic's EMR at 6 a.m. and 2 p.m. The information includes basics, patient demographics, your facility or location, the date and time the event happened, who they saw, the admission reason, and if there's additional providers that are also participating in CPAR, they will also be notified at the same time. Anila, I'm going to pass it over to you to now show how you're looking at the ER information from a confirmed panelist.
Perfect. So the first measure that we talked about in the panel reports was really about kind of that relational continuity and how do I improve those for my low continuity and get them more to my high continuity. Another way to look at continuity is to understand how that patient is flowing through the system and how do you improve that management and information continuity back to you. So 3 particular measures that might be relevant here are ED visits, particularly those that have been to the emergency department 4 or more times within a given year. ED visits for minor conditions. So these are conditions that the patient likely could have seen a primary healthcare provider for and did not need to visit the ED. And hospital readmission. So how many patients came back to the hospital within 30 days of a discharge. So let's look at that in the panel report. So what you see here is a screenshot of the ED visits measure. But what I would love to show you is how it looks like live so that we can begin clicking on those numbers again and maneuver them. So let's do that. So Sheena, I'm going to share my screen now. So the first measure that we talked about was this ED visits. So let's look at it, right? So again, same kind of layout of the page. You have a little bit about the measure and some of the kind of what each of these numbers mean here. But the table we're really interested in for the ED visits is, well, how many of my patients had a visit to the emergency department? So for this particular sample physician, 15% of her panel did, which equates to about 163 patients. So how many of those actually went to the ED 4 or more times, or is maybe qualified as a frequent user of the emergency department? So you would click again on this I or this number 8, and that screen would pop up. And again, if you're viewing a confirmed panel report, you would see actual PHNs. And you can begin to see, well, this patient here went to the ED 6 times. Actually, the first 3 patients did on this list of 8. One of the things you might want to think about, and this is something that you and your team could discuss, is whether it's worth flagging these individuals in your EMR. Do you want to identify who's going to the ED 4 or more times so that when you get an e-notification from CPAR, which is live, you might say, oh man, we had tagged these individuals. And last time or last year, this patient went to the ED 6 times. I just got an e-notification that this patient is back in the emergency department. I may want to action what is happening here. And of all the e-notifications that I'm getting, I may want to focus on the individual that has ended up in the emergency department multiple times in the previous year. So that is something to consider with you and your physician team that you're working with. The second measure that may be useful here from the panel reports is potentially avoidable ED visits. So it's really important to understand the first measure, which we were looking at, which was ED visits, which was all ED visits. Here, what we're looking at is maybe a proxy for access, because these individuals who had a potentially avoidable ED visit had an ED triage score, which means they came to the ED and were triaged as less urgent or a non-urgent case. And when they were discharged from the ED, they were discharged with a diagnosis that is considered to be potentially avoidable by the potentially treatable by the family physician in their clinic. In total, those that are have a potentially avoidable ED visits, these patients have a condition that have a less than like 1% likelihood of being admitted to hospital. So that's a little bit about this measure, which you can find on the right-hand side. For this particular physician, the percent of patients with an avoidable ED visit is not that 15% anymore, right? It's now at 2.4%, so a much smaller number. And again, you can click on that 5 and begin to see, well, who are these 5? What's also really neat is you can see how those individuals were distributed to the ED based on the time of day. So did they go to the ED during office hours, which is this kind of dark purple bar? Did they go in after hours? Did they go in other hours? And so you can begin to kind of navigate if access to the physician may be a concern or not. So let's click on the number 5 or this I and see what we see. So again, we're seeing 5 patients were admitted or went to the ED for a potentially avoidable visit. You can identify how many of those patients went once or twice. So in this particular case, 1 patient went twice. And you can play around with the filters if you needed to as well. In this particular case, the number is so small that the filters are probably not as useful. But again, this is something for you and your team to talk about. Is this an individual you want to flag as someone who's gone to the ED for something that could have been seen in primary care? Because if that person ends up on your e-notification list again, you may want to have a conversation to say, what might have been the struggle for that patient to not come in to see the provider, and why do they choose to go to the ED instead for their care? And the last measure that I want to share with you is unplanned hospital readmissions. So this measure looks at how many patients were discharged from your panel of patients from a hospital. And of those patients, how many of them ended up with a readmission either at 7 or at 30 days for any cause? So in this particular panel for this physician, you could see that of her total panel, 56 of them had a hospital discharge. None of them were readmitted within 7 days, but there were 2 that were readmitted within 30 days. Again, you can click on this eye, identify who those individuals are, and potentially look at their chart and see what might have happened here. What's really neat about this is if you're looking at a PCN level report, what you can do is begin to identify whether things like ED visits, potentially avoidable ED visits, or unplanned hospital readmissions is a concern for your PCN or not. How big are those numbers at the PCN level? And panel reports are a good way to sort of point you to what might be areas where you need potential work versus areas that may not be of concern right now to you or that physician. So I just want to kind of point you, we saw the live demo, but this PowerPoint slide is there for you as well. So here's what the ED visit one looks like. We looked at that. The next one is potentially avoidable ED visits. And so we looked a little bit at that screenshot, and you can see how office hours, after hours, and other hours are defined. And if you go to the next one, and there's your readmission one. And with that, Sheena, I'll hand it back over to you.
Thanks, Anila.
You're welcome.
This is really great. You're making that connection between whether clinics and teams have an HQCA confirmed panel report, whether they have it before they participate in CII CPAR or after. There's still that connection of them using different types of data to start working towards that active panel management.
Perfect. And so in this, some of the questions we get regularly is, well, how do I request a panel report? And how does that process differ if a physician wants to request it directly, or if perhaps you as a delegate would also like to access the report and would like to have the physician's permission? So let's start actually from the very bottom, because this is probably where this audience is. So if you are interested in requesting a confirmed panel report and you're participating in CPAR, all your physician has to do, if he or she would like access, is to go to our request form, which is request.hqca.ca, and fill it out with name, prac ID, email address, and they would do this annually for every year they want a CPL report. If you as a delegate wanted access to that report, then you would fill out an online delegate request, again, the same website, request.hqca.ca, input your information, your name, whose physician report you're requesting. And when you do that, an email will come to you with a PDF document that will ask for a physician signature, just to kind of give us that security that you have spoken to your physician about requesting their confidential report and having access to it. And here is the physician signature to back that up. And you would send that to us at the HQCA, and then we would produce a similar report for you that we did for the physician. That's probably kind of the easiest route. So participating in CPAR, requesting a confirmed panelist report. And then I won't go into all of these details, but you see above what you would do if your physician just wanted a proxy report, or what you would do if your physician wanted a confirmed report but was not yet participating in CPAR. So just a quick kind of a reminder. So what did we cover here today? So we talked about 2 different products, right? We talked about CII CPAR, and we talked about panel reports, and we talked about how both of those in conjunction can improve your continuity, that both of these products can probably improve lots of things, but one approach is to look at how they improve your continuity. And then as a reminder, some of the web links provided here is where you can dig into some additional tools and resources for both of these